We're going to be hearing from Hudson, Berrey, and Hailie, Uren. They're going to be discussing infections and rehabilitation challenges.
Yeah. Well, the first challenge is me and computers. Okay, so I had a really nice presentation all apart, and it's up in the cloud someplace, but I'm not smart enough with the computers to be able to figure out how to find it. So anyway, I'm going to walk just off the top of my head this presentation. And so why is it important? Rehabilitation and infections are what is going to be the legacy of this war. Long after the bullets stop flying, you will still have people to take care of with infections, amputations, spinal cord injuries, all the rest of that stuff that goes on long after the bullets have quit flying, the armies have gone home, but you still have this. In the history of war, infections has been the biggest killer of soldiers. This has been throughout history. The Romans actually had a very good system where they had a surgeon assigned to each cohort. With the fall of the Roman Empire, that was lost. And it took us centuries to get that back. Up until, including our Civil War, which I'm familiar with, the wounded were often could be left on the battlefield for days because we did not have adequate evacuation methods. So if you have an amputation, or if you have a patient who is injured on a battlefield, staying there for days, you know that they're going to have an infection when they come out of it. Well, we have advanced a long way since those days, or have we? One of the things that has happened with our progress in military medicine has been our rapid evacuation of patients from the battlefield. So my background is I spent 25 years in the Army, and then I spent 20 years in the university. I've taken care of lots of wounded soldiers throughout my career. I've done a lot of teaching on this subject. Many of the advances that we've had in medicine have come through our conflicts, through what we have learned in taking care of large numbers of patients in a very short period of time. Antibiotics, external fixators, the concept of a fast team, a forward surgical team, so that there is and this is something that our Army developed from the Israelis. So they had a surgical unit, one terrain feature behind the battlefront. So that fast team is a surgeon, general surgeon, an orthopedic surgeon, anesthetist, scrub tech, and a nurse. And they can operate independently with the supplies they have for 72 hours. And then their resources are exhausted. Resources in terms of equipment, IV solutions, dressings, and whatnot, but also the personnel resources. You can only operate at such an intense level for a certain amount of time. The one aspect that we have had throughout our recent wars is we have had prompt evacuation from the battlefield. We've been able to get So in my experience in Iraq, we were able to get a patient from the time he was wounded to the time he was in my operating room within an hour, as a general rule. And then when I was done, and other surgeons, I'm an orthopedic surgeon, as we got done and we got our dressings on, the patient was ready for transportation, another helicopter would be landing to take that patient down farther behind us. At which point they may go back to the operating room there, or they would put on a plane and be in Germany at our big military hospital within 24 hours. And then they would undergo another operation, a second washout, generally within 48, 72 hours. Then bandaged up, packaged up, and sent back to the States on special airplanes. One of the things we learned between Desert Storm and Iraq is that we have intensive care units in our aircraft, in our medical evacuation aircraft. So we can keep people who would need, we didn't have that in Desert Storm. And that was one of the things we learned from that. What is going on in Ukraine right now is very important for all of us, all right? Freedom is on the line here. And it bothers me when we don't have the popular support and the understanding of this in the West, in our country, and the rest of Europe. Because what happens here determines the fate of mankind in my eyes. The other thing we're doing is that we have to learn from what's going on here. Because in our next fight, and right now our military is developing plans for how we're going to fight the Russians or the Chinese in our next battlefield, where we won't have control of the air, and we will have long-term evacuations with this. So with that comes infections. All right. So infections are going to be, so my friend here, Hailie Uren, was my colleague that I discovered on one of my early trips to Lviv and working with St. Panteleimon and Unbroken. And she is a clinical pharmacist. And she is passionate about dealing with infections. And I really love this. So why do we get so in modern days, why do we get some infections? And then we heard about this morning. There's prolonged evacuation times. The most important aspect of preventing infections is good surgery. It's good surgery. But we can't teach that in our civilian training programs because we don't have a model for it. I've taught residents my entire life, and there's nothing in civilian medicine that is comparable to a war wound, and how you have to be very, very aggressive in dealing with these wounds because they're all very dirty, and you have to be very aggressive at being able to cut away muscle, and we're taught we got to preserve all the tissue. That's our teaching, but it's a different situation, and we relearn this every war. Okay. So we work with, in teaching surgery so I'm an orthopedic oncologist. I'm a cancer surgeon by trade, but I'm also a military surgeon. And when you're an orthopedic oncologist, you deal with infections, right? You deal with everybody else's complications. You're the last resort. So that's how I learned how to deal with infections and deal with amputations and whatnot. So these are going to be the legacies of this conflict. So we have lots of infections here in Ukraine. Polymicrobial and multiple drug resistance. And Hailie and I have been delighted to work with her. She has a wonderful experience with this. here in multiple places in Ukraine, as well as in her home country, that's why, of Australia, which is why she talks funny. So she has really the meat of the information for this talk about dealing with infections. So I will turn it over to Hailie.
Dobry den, мене звати Hailie. Я з Австралії. Я клінічний фармацевт. Я працювала у 5
I'm a clinical pharmaceutist and I'm working in 5 Ukrainian hospitals. I think I'm a Ukrainian here and now in English.
So I have been working in Ukraine since December of 2022 and all across Ukraine, from the east through to the west. I now work in the west in the largest health union, hospital union in Western Ukraine. So I have a reasonable understanding of the challenges and some of the opportunities for improvement that we could be doing in the hospitals in Ukraine. So this is just my experience. So this is a very simplified version of the trauma pathway. Someone is wounded, they go to a trauma stabilization point most of the time. They'll go to a secondary hospital for debridement, stabilization, and then they repeat that through to about 2 to 3 hospitals before they end up in a reconstruction hospital. Then after reconstruction to rehabilitation and then reintegration. So approximate timeframes, just based on my experience, it can obviously vary, and especially with the change in the front line and where the trauma pathway occurs. Now, what's interesting about this? So when I first started, the patients arrived on average about 25 days after injury in the West. So 25 days up to a year later, that patient could still be in the acute hospital. That's a really long time to be in an acute hospital before they're able to be rehabilitated and reintegrated. Why is that? So in general, are the patients infected when they first are injured? No. Are the patients infected when they first go to their trauma stabilization point or their secondary hospital? No. So why are 90 to 100% of patients arriving in the West heavily infected? It's because of the hospitals, unfortunately. It's a really, really difficult situation, but the patient does not have an infection when they are injured. So what we do in the hospitals is absolutely critical to getting that patient from their injury through to rehabilitation and through to live their life. Infections severely impact rehabilitation. Patients with infections may have started, for example, a mine blast. They have an injured, I'm not an orthopedic surgeon, so excuse my layman's explanation of the injury, but they may have just their foot, a traumatic amputation. They may have a below knee traumatic amputation. Then they have an infection. That amputation goes from below knee to above knee and then goes right up the leg because of the infection. So the significant impact of rehabilitation of that patient is dependent on whether we can keep the patient clean through surgery before and to try and prevent an infection. I don't know the full statistics, but I believe that a below knee amputation, about 66% or more can mobilize after below knee, and it drops significantly if it's an above knee. So we need to do everything we can to prevent these infections, and when the patient becomes infected, they are rapidly treated with the correct antibiotic at the correct dose, correct frequency, correct duration to prevent further damage to that patient. Yes, amputations sometimes are necessary. Sometimes the limb is not viable. But if that amputation has occurred due to infection, that to me is absolutely preventable. I had a mind blank what I was going to say next. Okay, so how have we managed to go about this? So I'm not sure if anyone's seen this. I know it's very small and the details aren't important, but this is an antibiogram. The first thing we need to understand is what bacteria are causing these infections, because how can we treat them if we don't know what's causing them? It takes a really long time to get a microbiology sample back. And I know this varies across the country, and a lot of hospitals in Ukraine don't have microbiology labs on site. So what you have to do is understand when that patient hits your door or hits the bed, you need to, and that patient actually has an infection, I'm talking clinical infection, you need to know what to give them as soon as possible. I would say the majority of patients who arrive in the hospital in the West, they're on absolute last-line antibiotics. And this is absolutely, absolutely not necessary. So the first thing we did, we analyzed 7,500 patient samples. And at the top are a list of all the antibiotics, and down the left-hand side is a list of the bacteria. Essentially, if you just see the red means that the bacteria is resistant to the antibiotic. And you can see a lot of red there. I think we all know that patients infected with gram-negative organisms are extremely difficult to treat. We don't have sensitivity. What's really important is that this type of antibiogram, it's not just a countrywide one. Ukraine is very big, not as big as Australia, but it's still very big. And this needs to be done locally because the bacteria sensitivity significantly differs from the east through to the west. So you need to be doing this to understand what to give your patient before you have a microbiology test result come back. Now, I don't even know if you'll know how to translate bugbear, but a big irritation. So last year, the Ministry of Health put out a recommendation to stop using levofloxacin and ceftriaxone. I see patients come in on these medications every day. So there are a lot of healthcare organizations that are still using them. Why are they using them? We have this general feel still that they're being used for exclusive or VIP patients. They're being reserved for only the most special infections. Unfortunately, if you have a look at levofloxacin, which is the second from the right, it does not work. That is why the Ministry of Health have said to stop using it. If you're using it for your patient, even if they're VIP, you're actually giving them a placebo dose. The same with ceftriaxone. Essentially the same with any of the quinolones, ciprofloxacin, moxifloxacin. They do not work. Stop using them in general. You can see basic antibiotics, amikacin, gentamicin, even meropenem work significantly better for gram-negative organisms. How are you going to do standard operating procedures unless you know what bacteria are in your hospital? So that information in the antibiogram was really critical. We met with the chief of each department. We understood what types of infections they were seeing. And then together with IPC, microbiology, and the champions in the departments, we developed empiric guideline SOPs. This will change hospital union to hospital union. We can't expect Ministry of Health to provide these guidelines when the bacteria are different in every location. So you need to develop your own guidelines. Now, I'm not sure how familiar you are with this. This is, I guess, a clinical pharmacy thing, but each of the antibiotics is divided into categories. The Ministry of Health and the WHO have said 60% of the antibiotics that you prescribe should be access. Less than 40% watch, less than 2% reserve, and 0% not recommended. Now, I know, especially when I first started, I thought impossible. How could we possibly give access medication to these patients who are severely infected? So, what did we do? First thing we did was restrict the antibiotics in the reserve category. So now, every time they need to be prescribed, someone wants to prescribe them, they have to fill out a form and they have to call through to the clinical pharmacy team to get permission. And I would say 9 times out of 10, the answer is no. Then we educated big time. You have all your standard operating procedures. You know exactly what bacteria are coming into your hospital. You know that you need to restrict your reserve medications, and then you educate as much as possible. What I found to be really effective is this, almost making it into something that's enjoyable. I say enjoyable, you can maybe ask the audience members how they feel about the education sessions. So there's a program, I'm not sponsored by this program, but it's called a Kahoot, and you can put your slides on there, and then the audience members can answer questions throughout your presentation with their phones, and it tells them who's the winner. Surgeons are very competitive. They all want to win. So it's really good at 8 a.m. when everyone's really tired and has to attend an education. It's a good way to get feedback as to whether the knowledge has been translated to your audience, and to also collect data on the knowledge ongoing, which is one of the requirements of Order 1614. So how did we go? So I'll talk about 2 departments, the surgery and traumatology, because there is a lot of overlap. Now, before I get into this, I want to talk about not recommended category. There are some very, very, very engaging medical representatives that keep pushing cefoperazone sulbactam, HEPACEF combi. That is not recommended for use. It doesn't have the evidence to say it's effective. I reviewed all the bloodstream infection and sepsis patients, and a lot of them, the patients who have died, have previously been on this medication. I recommend stop using it. Use medications that have evidence. So that is the black category in the pie graph. So the first, you set a pilot department, and we set the surgical department. So approximately 40% were access medications such as cefazolin, amikacin, for example, basic penicillins. And this was at maybe 12 months ago, that was how we looked. Now, 57% are access medications, and you can see the length of time the patients are on the antibiotics has gone from 6.1 days down to 3.43 days. If a patient isn't on antibiotics, a lot of the time they're moving on through the journey on the trauma pathway. You can see that if you change over to access medications and watch medications, it's not going to have any detrimental effect for your patients. It's actually going to be a lot cheaper, approximately 1,000 grivnas cheaper. It's going to improve how quickly your patients are treated. Cefazolin, those aminoglycosides, they actually work a lot quicker than medication in watch and reserve. Now, does that actually translate to the patient? I needed to have a look at how long the patient was staying in the hospital. So before this program was implemented, in general, we were quite standard, we were quite consistent with approximately 6 days. And over time, there is a significant reduction in how long the patient stays in the hospital. Now, we receive the patients after probably attending all your hospitals. They're very complicated patients. We share the same patients, and we are able to get these patients out to rehabilitation much faster now. Traumatology, they have a special place in my heart because with the beauty of traumatologists or orthopedic surgeons, they don't want to think about antibiotics. You tell them what to do, they'll do it. They know their scope and they know that they don't want to deal with antibiotics. So the uptake of such guidelines, such SOPs, is the best for traumatology wards. It's how we've maintained this friendship. So now the traumatologists have been significantly using cefazolin. How are they using so much cefazolin? Because they're giving every single patient prophylactic cefazolin now. I want to talk about cefazolin a little bit more. With cefazolin, in the guidelines in Ukraine and in the compendium, the recommendation is 1 gram to 2 grams. how many of your patients who are coming in and getting surgery are under 50 kilos? I would say probably 5%, if that. If your patient is over 50 kilos, it is always, always 2 grams. We've got our traumatologists to start doing that. And the results, this is the length of patient stay. So what do we know from this? We know that choosing, if you investigate your bacteria, you need to know what bacteria you have. You can't rely on microbiology tests to come back very quickly. The microbiology team are understaffed, under-resourced, and may not even be on site in your hospital. It's going to take some time to get test results back. You need to know your bacteria, and this can be found. It's not easy. It took a long time to collect this information because we started doing it by paper, getting every single microbiology report that on paper and collecting this data. Our IT team soon after helped us to collect it digitally, or they found a way to collect it digitally, but we collected it on paper. It's hard and it's really boring, but it's really important. Then from that information, you need to develop your SOPs based on what your bacteria is sensitive to. Then educate, educate, educate in the most enticing way possible. I bribe people with chocolate to come and answer the questions in the morning. Surprisingly, we have a lot of sugar lovers at 8 a.m. Then you need to make sure, I can't remember what it translates as. You need to make sure that you're treating as per evidence-based practice. This is really tricky in Ukraine, and this is something that I think will be interesting tomorrow to discuss, because the doctors of Ukraine, you have these very strict, I guess, rules or guidelines and previous training as to what the generation above you and above you and above you have been taught, and this general culture of sticking to what your boss has taught you. Unfortunately, the rest of the world has moved on, and a lot of research has been done as to best practice, and we need to stay across that. It's challenging. A lot of the evidence is in English, but Google has a beautiful translator. You need to stay abreast of evidence in the world. What the compendium lists, what tabletki.ua lists, that's treatment doses before the war. It doesn't apply now. The infections are different. The resistance is different, and we wouldn't be in this situation if those recommendations were correct. We need to stay abreast of evidence. So, these are my takeaway points. And I know it was, I guess, mentioned to me that there may be an opportunity to send through recommendations to the government, Ministry of Health, etc. But I believe that what we need to be thinking about in the future is updating evidence available to our doctors on treatment, of best practice treatment. I know there's the fear of being sued if you deviate from the Ministry of Health resources. I know that. I've worked across 5 hospitals. I understand. So how can the Ministry of Health support you to make the best practice decisions? It needs to be worked through. There's not an answer that I have. It's about building, I've just built relationships, and we have really academic conversations, sometimes arguments, but we need to be focused on what's best for the patient, how to treat the patient, before we need to think about perhaps outdated information. Controversial, I know. So I'd like to say thank you. It's really critical that we address this, because the patients ending up in rehab a year after their injury, yeah, it may have been cheaper to amputate, but what about the cost of that patient long term? What about the cost of rehabilitation? What about the cost for changing everything in their life to have disability access? It's significant. It's cheaper short term to amputate the limb. What about infections in the abdomen or the head? You can't amputate those. We need to be really focused on this. Thank you.